On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Discontinuing Telemetry for Your Hospitalized Patient, Translating Practice Standards from the American Heart Association. My name is Chris Mamrell, and I will be your moderator for this program. A copy of today's slides is available using the link provided in the chat box. The chat box can be found by clicking on the chat button in the lower right corner of your screen, and then you will see the chat bubble. The webinar will be available in a few weeks on the Patient Safety Authority's YouTube channel. We welcome any comments or questions, and all materials are provided for your educational use. Now I'd like to introduce our speakers for the webinar. Dr. Kristen Sandow is a professor of nursing at Bethel University located in St. Paul, Minnesota, where she teaches graduate and undergraduate students. Dr. Sandow has over 30 years of experience in acute cardiovascular patient care, during which she taught ECG monitoring classes and helped lead teams to implement evidence-based monitoring practices throughout a large hospital system. Angela Fink is an instructor of medicine at the Mayo Clinic in Rochester, Minnesota, where she practices cardiology. Angela has over 20 years of experience in cardiovascular patient care in both the inpatient and outpatient practice. In the outpatient practice, she specializes in cardiac sarcoidosis and heart failure. In the inpatient setting, she practices across all inpatient cardiology subspecialties. Dr. Sandow, I will now turn the program over to you.
Thank you so much, Chris. We are just happy to be here today as we are part of a national and even international effort to try to increase appropriate ECG monitoring. Thank you for inviting us. So today we're going to talk about how hospitalized patients, we're noting that they're increasingly receiving continuous ECG monitoring or telemetry outside of the ICU when they really no longer meet criteria for this. We have the American Heart Association 2017 update to practice standards that provide criteria for duration, for how long patient populations need monitoring. So recently, we've been seeing an exciting increase in the number of publications and presentations of hospitals that are using protocols to discontinue ECG monitoring. What are some of these protocols and who is responsible for them? So during this time, we're going to provide some examples of electronic health record prompts and nurse-led protocols so that you can compare them and consider what method might be best translated to fit your clinical practice. So at the end of the session, we're hoping for 4 accomplishments by the learner. So number 1, reviewing the 2017 practice standards to find where they are and the best table to note discontinuing ECG monitoring recommendations. And number 2, compare 2 possible methods. So Ehr prompts or nurse-led protocols in current use for discontinuation of telemetry monitoring of hospitalized patients who no longer meet criteria for monitoring. Number 3, list 2 pros and cons for each of these methods. And number 4, determine which method or combination of methods may be best translated to fit your practice. So before we start, let's just make sure we're all on the same page in terms of context. What we're discussing today are patient populations not in the ICU. So in the ICU, those patients are deemed to have an indication for continuous ECG monitoring. So during this webinar, we're addressing units outside the intensive care, and a number of terms are used to describe these. You might use the term progressive care unit for your units, or intermediate or step down, and telemetry units may describe another unit where perhaps they're less critical. So just a reminder to direct people to the update to practice standards published in 2017 as a scientific statement from the AHA, in which we presented by patient population the appropriate use of monitoring for arrhythmia, QT, and continuous ST segment, if appropriate. And so we had a great team working together to come up with these. And the paper turned out to be rather comprehensive, meaning that it might be helpful to quickly direct you to Table 7 as a quick summary for indication and duration for patient populations. And you can see the columns are the population and then arrhythmia monitoring recommendations, as well as any possible ST or QTC considerations. So the terms that we used are indication, when to start monitoring, and duration, when to stop monitoring. We have a lot of motivating factors now. You can see in the last few years, organizations are coming together because we've been motivated to discontinue telemetry when no longer needed, to reduce delays for admissions from the ED, potential diverts, to deal with the unavailability of monitored beds, and that can impact the patient flow out of ICU or to the regular units. and cost, inpatient length of stay, and then in terms of the end user, alarm fatigue, discomfort to patients, and workload of staff. And we have, of course, a Joint Commission safety goals for reducing alarm fatigue, and we have the Society of Hospital Medicine and American Board of Internal Medicine's Choosing Wisely campaign, in which we are really encouraged to avoid ordering continuous telemetry monitoring outside of intensive care without the use of a protocol that governs continuation and encourages the use of discontinuation protocols. So that's what we're going to talk mostly about today. But first, let's just make sure a quick overview. What we're seeing in my experience and what I'm seeing in some other publications are the examples of patient populations that are often over-monitored without an indication, low-risk postoperative patients, patients with chronic PVCs that are known, patients with ICD or pacemakers that are existing with no active cardiac issue, those with permanent rate-controlled atrial fib, or those hemodynamically stable low-risk patients without a significant heart condition that are admitted with pneumonia or GI bleed. Examples of inappropriate duration would include if a patient had been unstable, perhaps with sepsis or GI bleed, but now are hemodynamically stable, are they continuing on a couple extra days with telemetry monitoring without really needing it then? Or patients who had significantly abnormal K or MEG but are now repleted and stable, or terminally ill patients with DNR or DNI covered status who are not receiving active treatment changes based on their monitoring. If they are, absolutely. So we're considering why we're doing that monitoring. So just brief overview. What are hospitals doing to prevent over-monitoring or education? Is education on its own effective? No. We have a really helpful paper by Chakravarthy and team that explains that. Education is important, but not on its own. So then we are focusing on nurse-led protocols as well as best practice alerts, BPAs, they might be called in your electronic health record. So Angie's going to talk more about the BPAs. I'm going to talk briefly on education and a nurse-led protocol. So let's take a look at Cleveland Clinic. Their Fairview Hospital did a 6-week intervention among patients transferring out of ICU after sepsis. And this was their target. They said, you know, we're going to choose specifically the patients that have sepsis that are stable. Do they need to go to a monitored bed after they're stabilized coming out of ICU or not? Can we skip that monitoring then if they're stabilized? So they set a goal that was specific to their organization. And they did repetitive and multimodality education for the prescribers, and they saw a 23.1% reduction of over-monitoring, which resulted in an estimated cost benefit, which they based on about $230 a day for telemetry. I want to thank them for being transparent about financial outcomes, because that is something that has only been happening recently. People have not been sharing cost, and it's been complicated on how we measure this. So be careful when you're translating practice standards, when you're making decisions about your goal for cost reduction and how you're defining that. What I'd like to point out that was very helpful in the study was they said they basically did 3 tiers of education, and the first tier was very low, just in terms of impact. The most impact was when they had the tier of education where there was a video of 2 nurses explaining the impact of unnecessary telemetry use on the end users. So the patients, they would wake up at night. Those that were borderline delirium would be having more delirium because of lack of sleep, discomfort. And then for the nurses and users, frequent artifact, reconnecting leads. So I thought that was super helpful that they had the end users, and that had absolutely the biggest impact. So I'll talk briefly about one example of a nurse-led discontinuation of telemetry. And this would be an example from Johns Hopkins. So Johns Hopkins has led the way in the last few years in a lot of areas, including really defining alarm fatigue and approaching it differently and customizing alarm settings per patients. Now, this is an example of one of their smaller initiatives where they focused only on a 15-bed medical unit with a capacity for 8 patients on telemetry. So in their nurse-led protocol, this is how they worked it. Each night shift at 4 to 6 a.m., the nurse assessed patient's cardiac rhythm and 24-hour monitor history. If telemetry discontinuation criteria were met, for example, no hemodynamically unstable arrhythmias, heart rate 60 to 100, The nurses made their recommendation during multidisciplinary rounds. So in the end, it really was a collaborative decision to continue or stop telemetry. Post-intervention, they saw a mean decrease of telemetry by about 25 hours per patient. So as you consider, can I generalize from this to my site? Consider the nurses' knowledge and skills. So these were medical unit nurses. What kind of nurses are you focusing on their knowledge, their skills, their baseline, ongoing education, knowledge and skills? Who's doing the monitoring? The nurses' time. So 4 to 6 a.m. is a very busy time. If we're going to be reviewing event histories on a 24-hour monitor, do you have the staff for that and the time? So patients aren't being ignored. So considerations, about who's going to do this and at what time. This was not a step down or particularly cardiac unit. This was a medicine unit, and then scope of practice. So this was very helpful, thought-provoking paper. And as we think about the pros and cons for nurse-led discontinuation, the pros would be nurses see the whole picture of this patient with continuity from shift report. And definitely we see a decreased cost related to telemetry if we're separating the telemetry cost from the nurse in the bed. Cons, without careful consideration, this may cross the line of nurses being asked to practice outside their scope. And so as we discussed, needs to be a very collaborative decision. Less experienced nurses may lack the knowledge and skills to make the appropriate decision or recommendation. And inadvertent discontinuation without context, such as post-procedure routine discontinuation without being aware of an underlying condition, could be of concern. And when we think about what would this be like on an intermediate unit where they're more acute, for example, if we're looking for heart block after a particular interventional procedure, after TAVR, after ablation, that it would put a lot of responsibility on the nurses, particularly if they didn't have specific education to what might develop after those procedures. So I'm going to turn this over now to Angie to talk about option B.
Well, thank you, everyone, for being here, and a special thank you to this group for allowing me to be here to talk about a really important topic. I also want to give a special thank you to Kristen, who was instrumental in writing those AHA guidelines for telemetry. And I will say that what I've used in my practice is that guideline, that table 7 that she pointed out, that really steps out the indications and durations for telemetry. And that has really been the crux to my practice as far as implementing either prompts in the EHR or protocols to start telemetry and telemetry when there's an indication or not an indication. So thank you so much for the work that you've done with that. And it really has been instrumental in shaping our practice. So like Kristen said, I will talk a little bit about EHR prompts. We've recently implemented EHR prompts in my practice. And so I can share a little bit of background as to what kind of options there are out there for EHR builds, what kind of pitfalls or pearls that you might run into or that I could share based on my own experience. So this is just a snapshot. I just pulled this off of a website, and it's a generic snapshot of what it might look like if you were to implement an EHR prompt. You can see that it pops up and says to order it or discontinue the order. Now it seems pretty simple, but you have to think about what's in the background of all this. What's in the background of all this is what's driving that prompt. What protocols have been built into the system to drive that prompt, as well as who's it going to. So this one particularly looks like it's meant for a provider to either order or discontinue the order. There are other ways to do this within your EHRs, which include a prompt going to a nursing task list, and that nurse would interact then with the care team to say, whether or not it needs to be ordered or discontinued. So there are different ways to do prompts to different individuals of the care team. It really is important for that to be tailored to your practice. And again, very intentional about how is that prompt fired? What pushes that prompt forward? What time frames or inflection points makes that prompt happen? You can go to the next slide. So UCSF, or University of California, San Francisco, did implement an EHR prompt, and their publication is listed here in some of the outputs from that publication. They used an inpatient unit where half of the patients received the EHR alert, or half the patients providers received a EHR alert, and that went to the ordering provider, and half of them did not. And what they found is that telemetry was discontinued 62% of the time that an alert was fired. So it means the alert was firing in the appropriate time frame and appropriate manner that prompted the provider to discontinue telemetry. Therefore, there are fewer hours of monitoring by about, looks like 41 versus 50 hours. But importantly, there was no change in the rapid response calls or medical emergency events. So for Mayo Clinic, we did actually interface with UCSF. We reached out to them and asked them, what did you learn? How did you do this? What do you have to share for us? You can go to the next slide. First, I want to share what our baseline was at Mayo Clinic. So Mayo Clinic, Arizona, and Florida have looked at how much over monitoring are we doing. And you can see here that they published that information, my colleagues published that information, and we found that's about $2,000 in healthcare per hospital per patient stay is used for telemetry that could be avoided. It results in a length of stay of about half a day or longer. And again, regardless of the duration of telemetry, we were not finding a difference in 30 or 90-day mortality or risk of readmission when we were discontinuing that telemetry earlier. Now, I'll preface the conversation to say we did make EHR prompts at Mayo Clinic, and we are in the process of evaluating those prompts and how they've impacted our practice, because we're still pretty early in it. Likewise, the trials and tribulations of going through a process like that are still very fresh in my mind because it was an enterprise implementation. Next slide. So what are the pros and cons of the EHR prompt? It really depends a lot on how you implement. I shared two kind of models by which you could have a nurse prompt that goes to nursing to discontinue telemetry, or it can be a provider. Now, with any prompt in our electronic medical records, you can ignore them. So the prompts could be ignored. The prompts could be fired at the wrong time and without patient context. So it could inadvertently discontinue telemetry. So it's very important that there's a context or a process in place to be sure that's not being discontinued inappropriately. The pros to that is that we do know it reduces the number of hours of telemetry. We do see that decreases the length of stay, and there's not additional cost in testing associated with telemetry. You can think about telemetry fire that there's telemetry alarm came up that there is a prolonged QTC. Well, many times we get an ECG, or the patient had more PVCs, so then we end up ordering electrolytes early. So you can see where the cost is associated with more telemetry means more testing. Next slide.
Thank you so much, Angela. Very helpful, and it's exciting. We look forward to hearing more about your outcomes with your change projects here there at Mayo Clinic, which is such a large institution. So if I might, I thought it might be helpful to just share from my experience working with a wonderful team to try to have our specific United Hospital more aligned with appropriate ECG monitoring. This is kind of the big picture as you're considering or you're working in your own hospitals. I like to kind of use the bundles materials, message, and marketing. So when you're working with your materials, thinking about your existing electronic health order sets, and we put in the AHA practice centers as hyperlink, and the order sets, many had to be adapted to fit the practice centers. And so I do want to give a recognition of hospitalist Dr. Steve Hanovich, who did a lot of this on his own in Playground, and he and I would just sit and he would pull together what had been really innovative in changing the practice to be something that providers then had to choose a selection for why their patient was monitored. And we had a one-page colored handout to guide the changes. And then being really careful to spend the time with the stakeholders. Big changes are hard. We all have so many changes that we're being asked to do. And so the messaging is so important. It needs to be tailored to each group. So for example, I'll just show our cardiologist decided our quality improvement lead cardiologist wanted an online mandatory education, and that fit in with their goals for the year. So I got to work with the team to develop that. The hospitalist wanted a lunch meeting education. That was in line with their culture. The residents and in-person in-service, and then the nurses, being that there were hundreds brief in-services, kind of more casual charge nurse checklist and handout, and changing the sign-out report to include a prompt about that. And then in terms of marketing, the champions are critical. You cannot succeed successfully in a change project without your nurse and physician champions. And then we did use some technology with the repeating 3-slide reminder in the physician's lounge. And then really incorporating the cardiologist, helping them understand when they sign off as a consult and they leave someone on telemetry, help us understand what we continue to look for. We would love to be able to use it as best we can as technology then, or leave a recommendation for when to discontinue. So one size may not fit all, and clearly what we've learned is that simply educating providers about practice standards is not enough, and the responsibility for discontinuing telemetry is ultimately the prescribers in terms of scope of practice, but really it is a collaborative interprofessional effort, and we can't use the word collaborative enough. One size does not fit all. So based on your hospital culture, you're going to be considering your baseline metrics so that you're setting appropriate goals and not too high or too low for your change and your for appropriate telemetry use. Look at the makeup of your healthcare delivery team, your providers, your nurses, your technicians. Who is responsible for watching the monitor? Is it a collaborative effort of all the nurses at the station with no one person? Is it is there a monitor tech that is remote or that is physically distant from the nurse's station? Do you have long hallways or circular hallways so that the monitors are viewed? So there's just a lot of things to think about in the bigger context. And then ongoing education and skills of whoever is providing the telemetry monitoring then. Because we sometimes will provide baseline basic education and then forget that ongoing education and skills is needed on an annual basis to make sure that we're providing the expertise to what we're asking for. Staffing and acuity and organizational culture.
So as Kristen, as Kristen mentioned or covered, one size doesn't fit all. So what are those pearls of translating standards into practice? It's really looking at what's right for your practice. So who are the right clinicians, or what is the right clinician group who's going to be best positioned to receive or act upon an EHR prompt, if that's what you choose, or whatever implementation of a process you put in place. Additionally, what is the right time? So for example, UCSF had published this piece, but also what we learned at Mayo Clinic is what's the right time to prompt to fire for the EHR. If it's in the middle of the rounds, will it get ignored? If it's in the middle of the night, will it get ignored? So what works best for your care team as far as the timing of when that prompt should fire that will net you the best outcome of the prompt being addressed accurately and acted upon accurately or appropriately? What's the right context? Now, I absolutely believe that AHA telemetry guidelines are the right context to use and to leverage these guidelines to your practice. So at Mayo, we took those guidelines, we tweaked things a little bit because we needed it to fit our practice. So look at those guidelines, alter them, in ways, or translate them in ways that best fit your practice, so that the guidelines are speaking to how you practice. And then remember that your operationalization of these guidelines and any process you put in place is dependent on your institution, your team constructs, your team culture, and those support systems. Some groups have telemetry techs who can say, it's time for the telemetry, we've discontinued, and they could push something to a group. They can be responsible for different things. And then other teams depend on frontline nursing or other allied health staff to be watching the monitor and can be taking part in whatever process you put forward. Next slide.
So we wanted to keep it short because we know everyone is so busy. So we have some additional resources that you can use. We want to thank the Pennsylvania Safety Authority, Patient Safety Authority, AACN, of course, and AAMI for alarms and monitoring expertise and working with biomedical engineers as well. These are just a sampling of some great papers that have come out just in the last few years. And now I will turn it over to you, Chris.
Thank you, Dr. Sandow and Angela. That does conclude the slide presentation portion of our program, but we do have a few minutes, so we'd like to begin a question and answer period. If you have any questions, please type them in the Q&A box found at the bottom of your screen. If you don't see the Q&A box, you can click on the three dots, then click Q&A to open the Q&A panel, and then direct your questions to all panelists. We'll try to get to as many questions as we can. While you're entering in those questions, I want to remind everyone that this educational offering does provide a certificate of continuing education for 0.5 continuing education hours. Those education credits apply to Pennsylvania and Minnesota registered nurses only. There will be an option to select your state following the completion of the evaluation. In order to receive the certificate of continuing education, each individual requesting credit must complete the evaluation and include their contact information. If you're the registrant of today's webinar, upon exiting the webinar, the evaluation will be displayed in a new internet browser window. For those of you who didn't register, but if you're participating as a group, please participate in the evaluation by copying and pasting the link found on your screen or in the chat panel into a new internet browser window. And we'll have that link up on the screen in just a minute for you. And we're asking for evaluations to be completed by 1:30 p.m. on March 1st, next week, by March 1st. Okay. So I do see some questions. This first question is for Angela. You work in a very large healthcare system with several sites. Can you speak to how changes to hospital cardiac telemetry monitoring may need to be examined and changed with specific considerations from one site to another?
Yeah, thank you. That's a great question. Absolutely, it has to be tailored to your practice, as we kind of touched on earlier. You know, we have destination medical center practices, and we have community health system practices as well. So again, really looking at what are the needs, where are the areas that you're over monitoring within your practice, and how does that best fold into your current state practices. Some of our groups at Mayo Clinic use a nurse-led telemetry protocol for discontinuation. Some use a prompt, an EHR prompt, that either goes to a provider or a nursing task list. So we've tried to be nimble in assigning that process to best fit the practice. We feel like we'd be most successful or will be most successful in tailoring it to practice versus forcing something that doesn't necessarily fit.
Great, thank you. This next question is for Dr. Sandow. In the update to practice standards, your team specifically mentioned that for some patient populations, you felt you didn't have enough evidence to provide specific guidelines about indication and duration. What are some of of those patient populations, and should hospitals share and publish reports about those populations, even if they don't have formal research studies?
Yes, yes, please. So we it's so exciting. In the last few years only have we seen this increasing. Even if it's a well done QI, yes, we need to see it. So specific areas that we lacked evidence to be able to make recommendations included a specific cutoff for what is severely abnormal potassium or magnesium. Are we going with less than 3? Are we going, for potassium greater than 6.5? So that kind of thing. Magnesium, when there's some contextual information around that as well, of course, if you're actively diuresing. So that is something that's going to be contextual at your organization. Angela mentioned tweaking guidelines, and we want people, if they're going to make changes, to measure so that we know, and then when we update guidelines, we can have that. So pulmonary embolism. So not a whole lot on that. Is it if they have a dilated right ventricle per echo? Is it when they're based on their FiO2 needs? Is it, and also regarding dialysis patients. So those would be some examples where we really need everybody to do some more sharing of telemetry outcomes. Is it helpful or not?
Great, thank you. I think we have time for about one more question, and this is for either one of you. Do hospitals bill for telemetry outside of the room fee?
Yeah, I can take that one. I think it can be done either way. I will say, like in my own practice, I know some of our sites bill it separately, and sometimes it's with a room fee. So it would be dependent upon your specific institution, how they want to pursue that or how they would want to implement that, but it can be done both ways, to my understanding.
Great, thank you. Well, I want to thank everyone for joining us today. If you do experience any issues accessing the evaluation or the Certificate of Continuing Education, please feel free to direct any inquiries to Shelly Meixel, and you can see her email on the screen right now. It's shmeixel, M-I-X-E-L-L, @pa.gov. And this will conclude our webinar for today. Thank you.